Welcome to episode 11 of the ARME Radio podcast, the show where we aim to offer accessible education to healthcare and fitness professionals alike and to bridge academic research to the clinical setting. We were very lucky to have Sam Spinelli join us for the discussion you're about to hear. Sam is a doctor of physical therapy, a strength and conditioning coach, and he's the co-founder of Citizen Athletics and E3 Rehab. And he also runs his own practice as the strength therapist, where he does online consults and in-person sessions with his patients. This was a really fun one to shoot because Sam is very well read and has great research literacy skills. And you can see this come out with some of his philosophies and his approaches to patient interaction, education, and treatment. As you can see with the title, we touched on the topic of hands-on passive therapies and active care and how these are closely tied to the general theme of this discussion in high versus low value care. A fun little tangent we got into near the end of the show was how Sam has been able to build this high value but lower volume model of care into a good and sustainable source of income for himself and his family, tackling a common false dichotomy presented in many institutions of high volume, low value care models being the only way to make a feasible income. High value, ethical, guideline-based care is totally doable, even as a new practitioner, as long as you have the patience and the work effort of sticking with it. We hope you have fun with this high-value content episode. See what I did there? And for more information and resources, be sure to visit us at www.thearme.ca. Give our Instagram page a follow at thearme.ca, so that's at thearme.ca. Check out the gang at E3 Rehab. Great content there. And for even more great content, visit Sam on his active Instagram page with the handle dr.samspinelli. Anyways, hope you enjoy the show. Okay, so we have Sam Spinelli here, who's a doctor of physical therapy and a strength and conditioning coach. He's also the co-founder of Citizen Athletics and E3 Rehab. So Sam, welcome aboard. And why don't you just kind of let the audience know a little bit about yourself, your background, and some of the projects you've been a part of.
Thanks for having me on, guys. Yes, so I initially got into this whole crazy world by getting started as a personal trainer initially, and then had some great mentors who encouraged me and progressed me towards a strength and conditioning role. I was very fortunate when I lived back in Edmonton, Alberta, that I got guided under some excellent high-level strength coaches in the area that very early on got me thinking more critically, being a lot more involved in research, starting to actually appraise and start understanding it more from like a strength coach level, which was very beneficial for my future endeavors. As that I went on in that strength coach role, I started to have a lot of athletes that were injured and not knowing what to do with them. And while I could just refer them out, I always looked to other strength coaches at the time that had experience as rehab clinicians as well. People like Charlie Weingroff and similar coaches that I thought were just the epitome of as good as you could get. And I wanted to follow in that suit. So then I went and got a doctorate of physical therapy in the US, practiced for a while, got experience in every major setting of physical therapy. I wanted to feel like I was very well-rounded and able to be basically dropped into anything. So I worked as a acute care physical therapist in the ER, worked in a neurological setting with spinal cord patients, worked in the outpatient setting, tried to really just cover the whole gambit, and then moved back to Canada. I've now been here for just over a year. I've got currently 2 in-person practices set up, one in a performance gym, one set of a weightlifting gym. And then I have, like you said, the 2 online businesses, and like to lift weights in my spare time.
With the online businesses that you've been that we kind of mentioned there, E3 Rehab is something that most of us have been exposed to anyways. What was kind of the what got that going? You've got a couple of colleagues there. You guys put out some really good stuff, but what was the inspiration to getting that out there?
So when we were initially talking, it was probably just about 3 years ago now. And my 2 business partners, Mark Sertica and Tony Camella, we had been discussing things online, going back and forth about how we choose to treat. We started a little journal club between the 3 of us, and we just regularly talk and hang out. And we were like, okay, so we see a consistent problem with a lot of the way the clinicians think, a lot of the way that clinicians choose to practice. How can we have a more positive impact? And it's something that we each try to do individually through our own social media channels. But in our agreed upon opinion was that as an individual, you'll never be as successful as you could be in a team setting. So then we wanted to then venture off and see how we could just improve our abilities to offer educational material and service more people as a collective than individuals. And that's where the inspiration of E3 Rehab came from. And then we started to work on different products, and initially just wanting to try to offer something to the general public from how you could handle issues, as well as for clinicians of this is the current most up-to-date evidence-based information on a respective condition, and this would be the appropriate way that you should probably treat it. And so we started to create products and programs like plantar fasciitis, where we did as much of a critical review of the literature that we have available, and then we seeked out the best people in the field that have the most current up-to-date knowledge that we could find on that. So for instance, with the plantar fasciitis one, we spoke with Henrik Riel. We had him evaluate the program, look at it. For anyone that doesn't know, he's one of the top leading researchers in the world on the topic. So we had him look over information, give us feedback, and then we tried to update it even further to essentially the best degree it could be, so that clinicians could learn from it and the general public would be guided on what they could do from self-management standpoint. And so we have a few of those, but we've started to shift gears more to a clinician focus, where we're trying to create more services to help clinicians, because at the end of the day, if we are able to reach a few people from a like a rehab perspective, it's beneficial, but there's way more clinicians out there treating in person than there are people looking for a one-off program online. So we wanted to be able to service more clinicians, help to create more educational offerings, because I'm regularly asked about, if I want to take a continuing education course, if I want to learn, where do I go and find this material? And most people don't probably want to take the route that I did of just sitting behind my computer for every spare hour I have and reading one-off random things and trying to put it together. So we're trying to figure out a solution to that problem now. And as we do that, we're still trying to make YouTube content, Instagram, Facebook, and make solid information that hopefully is beneficial to people.
With you talking about, putting together some of the latest literature, praising it, a conversation that we have basically every day or every other day here is maybe the importance of the use of guidelines from a practitioner or clinician point of view. And Ben can probably correct me on the numbers here, but there's that paper by Zadro.
There's the 2019 Zadro paper was like 54%, but then
Okay.
The one that I think is really important is the follow-up, which was Zadro Ferreira 2020, and what they looked is like the last decade, and it was like in the last decade, based on literature that's come out, like only 35% of interventions being used by practitioners are like founded in either a guideline or a most up-to-date meta-analysis and systematic review. But the really damning statistic is 70% of interventions used are non-recommended. And that to me is like, okay, so someone's coming in and they're getting the gambit thrown at them, right? They've got an Achilles tendinopathy, and now we've got Acu, Graston, laser. Like, you were just throwing things and hoping something works. So Dave, you can go again. That's my fact check.
Yeah, no, that's perfect. I get the numbers mixed up, but it's either way, it's not good, and it's not good throughout the professions. And some of the discussions that we might have over the internet and stuff, you'll usually hear people saying, well, that's not what I've seen in clinic. There's a lot of anecdote usage, but it's obviously pretty important to try your best to use the best evidence. So what are your thoughts on using the guidelines and maybe making that a little bit more accessible for other practitioners? Because that seems to be something that you guys are trying to do, right?
Yeah, exactly. I think that's a good analysis of it. Most cases, people are either A, providing a treatment that has low value or no value, and they may be, in addition, throwing everything else at them. It's less common to find someone who is solely using information that is supported by the clinical practice guidelines. And a lot of times, honestly, the CPGs are pretty nice and reasonable. They don't really exclude things unless it's pretty bad supportive information. I think even in the case of something like, what was the one I was looking at not that long ago, hip osteoarthritis, they still support the use of mobilizations in hip osteoarthritis, even though the literature basically supports that it does little to nothing beyond like a 30 minute to 2 hour reduction in pain. So even though it's not having any substantial long-term benefit, even when we say long-term of being like a couple of days, it still shows that it can help someone have a slight pain reduction. So they're still saying that you could do something like that, which personally I would argue against. But so my point there is that the clinical practice guidelines are fairly reasonable for a lot of what they still cover. But yeah, they disregard a lot of things. And the challenge, I think, is, like you said, a lot of anecdote. Clinicians really hang on to it, especially if they've been either a person who's practiced for a long time prior to being told about evidence-based practice or finding any of these clinical practice guidelines. If there's someone that was a student and really inundated in these different kinds of questionable practices, or if there's someone that just really doesn't understand research, which in my opinion, that last part is a huge problem in the fields. Right now, we're doing a virtual mentorship with E3 Rehab, and we've got a mixture of like last year students. So we have, actually I think all the students are doctors of physical therapy, but we have chiros, ATs, people across multidisciplinary rehab professions, and all of them very open and honest that they don't feel very confident reading research, even though they're basically at the highest point, and they're individuals who are quite active in trying to understand it. And as we've sat down and we're 2 weeks in and we've looked over different literature, they really did have a hard time comprehending what it says. And it's a common theme. Like for me personally, if I were to look back at the class that I graduated with, roughly like 46 students, I would say maybe 2 or 3 really understood what we read in research and at how we would be able to discern what certain pieces of information say. And because of that, it makes it more challenging to really be able to understand the uncertainty in some things, the effect sizes, the confidence that we can have in these different things, and also appreciating how there's multi-layered information sometimes in what's having possibly an impact on the effect that we even see. The simplest thing of like these different contextual effects that we see from the way that you speak to a patient, the way that you interact with them before the treatment, the way that you interact with them during the treatment, the environment of the room that they're being treated with, all these different things are heavily ignored by clinicians. Particularly, I would say that the clinicians that choose to use these more non-supported interventions. So we just run into this issue where I think that it's a big part of we need to improve from an education standpoint for clinicians, which is something that would ideally be done in the school system, but is honestly a really big undertaking that I personally don't want to deal with. So I'm going to try to work around it. But I think hopefully if we can have more appreciation from that from individuals who have bigger reaches online, as well as starting to get more grassroots level and being able to show that you can have improvement in more evidence-based interventions, it would hopefully have an impact on more clinicians and a greater discussion across different platforms. So something like this, where hopefully there are clinicians that are going to listen to this that, you know, maybe they have at least a little bit of back and forth. They're thinking about whether or not they should be doing certain interventions. We could maybe win them over. Yeah, hopefully.
So in the nature of things being multi-layered and nuanced, like you said with the hip osteoarthritis guidelines, how it says it does recommend some mobilization for some it does recommend using it, even though the effect is minimal within a few hours. But then some people would argue, well, it's in the guidelines, we can use that. It does have this benefit, however small. And you mentioned you would argue against that. What is your perspective there and your reasoning there? I mean, I've got my opinions about that, but I'd love to hear what you have to say.
Yeah, so my general stance on medicine is that our goal is to maximize long-term outcomes first, then begin to worry about short-term outcomes. Now, with that said, it really is case dependent on the degree of short-term outcomes mattering. Like if we're talking about someone is in a car accident and we're deciding whether or not to give them pain medicine because it's going to decide the degree to which they can manage a severe injury over the next few hours. Well, okay, like, yes, I appreciate that. Giving them pain medication will make their life significantly better in the short term, and it may not have a big impact in the long term. That's not the same conversation as this person has 2 or 3 out of 10 pain, whatever that may mean. And doing mobilizations for the next 15 minutes is going to change that for the next couple of hours. Like, that's a different conversation. And I just preface that because there are people that will sometimes reach out to me and say that these different kinds of arguments about that kind of situation, like using anesthetics during surgery. This is not the same kind of conversation, and it's a little bit outrageous to make that argument, but nonetheless, I'll preface it. But in general, my focus is, if we are looking at something in the short term and it has a relatively small effect size, so like that example of a mobilization having a relatively minimal impact, at least when we're looking at it from a few hours to a few days, and then we compare it to the long term, where if that individual got that mobilization on that day, would we know any different 6 weeks later? And in essence, we don't see a difference. And when we start to evaluate the degree to which we should invest money into the healthcare system, which is a very challenging conversation, but when we look at the current time, Canada and the US have a lot of healthcare spending, and we are not necessarily seeing improved outcomes. We're not seeing people are having improved quality of life. We're not necessarily seeing people have improved longevity. We're not seeing a lot of these different morbidity rates changing. It should be a conversation about then, what do we need to change? And if we see that the way a lot of medicine has shifted across the last half decade, it's been towards increasing the amount of spending that we do on these more short-term based interventions. And again, it's a very long conversation as you start to expand out past our sole profession. But when we're looking at what we can do, when we start to look at what has the biggest impact across a longer length of time, so different things like sleep management, behavior management, exercise, possibly nutritional interventions, depending upon the case, and these different kinds of things that we could do with individuals that would also not necessarily take more of my time, but would just require me to guide them and support those people and provide them with ways that they can do it. Something that I would call would be highly skilled care versus something that doesn't necessarily require a lot of skill, something like pushing on a piece of general flesh and having some general effect that doesn't currently support necessarily requiring much skill, and focusing on those things first. Once those things are all in check, then maybe considering the alternatives. So at least in my current practice, I start off everything having discussions with patients about what we could do from a lifestyle standpoint, what we could do from an exercise and behavior standpoint, and then possibly things on nutrition, possibly things in those other kinds of areas. And then if everything is checked off, if they are just the most phenomenal person and they are looking for some additional, what I would classify as low value care, I would consider it. At least in my current time, I've been a practicing clinician for a few years now, and I've never built a single unit of manual therapy, and I've never built a single unit of modalities. So if that references anything to people out there, at least in my personal opinion, we have a relatively limited time frame with people. They have a lot of struggles in figuring out answers to these things that if you are trained in them, you're able to provide a lot more value to them, I think. A lot of people struggle in figuring out how they can make exercise fit into their life, what they should do for exercise, what they should do to modify their sleep to improve how much quality sleep they get, how much quantity sleep they get, how to figure out ways to be able to adjust positions so that they have less symptoms throughout the day. These kinds of things that, would probably generally fall under more like the therapeutic activities, therapeutic exercise, those kinds of classifications for billing. And so that's basically where I spend all my time.
Yeah, I find that like that's the kind of the point you ended on there is one that I know that we talk about ad nauseum, really, is that this idea that like we have hilarious debates on the internet about should we do this intervention and should we not? And I'm sure we've all partaken in those because they're fun, because you like to share your opinion. But the reality is, like you just talked about, is like so many issues that walk in are a social determinant of health issue or a lifestyle health issue. And the resulting back pain, shoulder pain, knee pain is such a small downstream percentile that it's like, if we strictly focus on like why that's happening, I feel like we end up in a just kind of a really like focused and non-appreciative view of everything, right? Like if someone's coming in and they're financially insecure or they're work insecure and they're not sleeping, they have a new child, like this is like their knee pain's largely probably the smallest concern of what's going on there, right? So my question really is like, how do you, because like you said, you look at that every time you talk to a patient and work with a patient. So how do you decide really like, where's that role between you are like a physical therapist or you're basically kind of like a lifestyle coach? So how do you define that role between the two? Or do you think it should just really be one?
Yeah, it's an interesting one because, so again, the conversation of this is medicine, I don't think that we have a lifestyle coach in medicine. It's kind of like this vague thing that has fallen through the cracks and it's kind of left for a lot of clinicians to kind of touch on. If you look at like, who is the person that should be speaking about sleep? Well, unless someone has a pathological sleep condition, we don't have anyone to talk to them. Like, unless you are completely insomniac, you don't have a professional who's designated to have that conversation with. If you do not have an eating disorder, which is a relatively vague diagnosis as well, but nonetheless, if you don't have an eating disorder, you don't technically have a person designated to speak to, or unless you have like a comorbidity like diabetes. So for the vast majority of humans that are moderately healthy and don't have any of these kinds of things, you know, like they're just struggling and they need some guidance, but they don't necessarily need a person who is like the sleep person and is going to give you sleep medication. You just need someone that's going to help guide you in, okay, well, maybe you need to work on changing your bed sheets more frequently. Maybe you need to work on lowering the temperature in your room. Maybe you need to worry about taking away these light emitting devices a little bit sooner before you go to sleep. Maybe we need to reduce your caffeine intake a few hours before you go to bed. These kinds of pieces of conversation is not necessarily under anyone's current hat. So for me, when I'm looking at like, where do I fill in the cracks as a physical therapist? When we look at what is our designated role, it's to help individuals in the management of pain and function, not to do manual therapy. Like, that's not my designated role. I can do that as a function of my role, but it's not what my practice job is. And I think that's where a lot of clinicians struggle because, you know, when I'm looking at what am I trained in, I am relatively trained in my function, but when we actually look at like where does the most of the emphasis go on, it's what can I do, not how should I think about what I do. And unfortunately, a lot of people will struggle in deciding then how to practice because I'm given all these random things that I could do, and I have this person who is struggling. I'm just going to throw a bunch of things at them and see what happens. And a lot of the times people will choose to throw the things that have the most appearing effect at first, not necessarily the thing that will have the longest lasting effect or the most impact on that person's quality of life in the long term. And that can be a hard shift, especially when you're dealing with someone who's currently in pain and currently struggling. Like you said, you've got that person that is a new mom. She has limited sleep. She has knee pain, and she just wants her knee to feel better so that she can stop worrying about it and focus on her kid and X, Y, and Z. And so it could just be like, I'm just going to needle the crap out of this thing right now, and she's going to feel better, and then she's going to love me for it. That sounds great, except for that she'll probably feel the same a few days later, and she will possibly still be struggling with the same general issues, and she'll come back to you and be in the same position of being reliant on you for that management and perceive that the special thing that she needs is to just be needled every time that she has pain. And that's not necessarily what our current body of literature would support for the best long-term effect. So then, while I could do that short-term intervention, we have all of these other long-term interventions that fall or long-term focused interventions that don't necessarily take more time than the needling. They just take a different perspective on it. And they hopefully will have longer lasting effect. Maybe not this like drastic, huge effect, but hopefully a longer lasting one, and get the person more ways that they can self-manage, which should theoretically reduce the burden on healthcare and allow that person to have more self-efficacy, which may not happen immediately. Like if we look at the literature on self-efficacy, it takes a while usually for most of these things to change. But if I provide them with tools and opportunities to do so, they can hopefully do that, which is agreeable with people improving the quality of their life across the long term. So with all that said, most of the time it's going to be something that can be less obvious, because when we're looking at, like you said, people have this perception of what we do, and people have an idea of how I am to practice, not necessarily what my actual job or my designated role is. And when I'm, again, looking at these determinants of health and these determinants of function, that a lot of those things are either not designated to any specific profession, but my job is to make those things change. Well, then I'm going to take up those things because they seem to have the best effect. Something like exercise, like who is in charge of exercise? I don't know. A physician can talk about it. A physician could theoretically teach someone how to exercise. They're just not going to do it because it costs way more for them to do it than for me to do it. And then theoretically, I could even then defer that out to someone else, like a personal trainer. Like in my current practice, that's what I do, because, I charge somewhere between $100 and $150 an hour. And I have multiple trainers in my designated area that I've made connections with and have vetted and made sure that I'm confident in referrals to them. And they charge more in the range of $40 to $70 an hour. So for longer term management of just exercise prescription, I feel comfortable in deferring to them. Now, that's not necessarily something that can be written off from an insurance standpoint. It depends upon people's insurance plans, but most of the time it's going to come out of the person's pocket. Whereas I could probably bill them for more visits under insurance, but if all they need is just to, get in better shape, I sooner to defer them to someone else for that.
Yeah, you said about 50 things that I wish we could just echo and plaster on a bunch of walls that everybody could read in every school. So I appreciate that. And the first thing that jumped to mind that you're talking about that is there's a article from 2002. It's Jules Rothstein. It's like a really famous one. It's like who we are versus what we do. And I find myself going back to reading that one anytime I see a study where it's like an A plus B plus C plus D plus E study versus usual care. And I'm like, okay, so we're defining physical therapy or chiropractic or osteopathy as just an amalgamation of random interventions. That's now what we're defining these professions as. So I appreciate you just touching on that, because like you said, that's not what it is. It's not like what we can do intervention wise. It's the whole picture. You also touched on the fact that like when people come to see you now, they have an expectation. Like if we're coming to see Sam Spinelli, they know exactly what they're probably going to get just because of the culture and the brand and what you've built for yourself. When you were younger and earlier in your career, did you have more of a struggle with that, where people came in with an expectation different to what you were prepared to offer? And if they did, how did you handle that? Were you able to say no to people?
Yeah, so I will say that I'm very fortunate that, number one, I came into this profession already with critical reasoning skills to a degree. It's definitely improved a lot over the time. And I also came in with a huge exercise background, which was very beneficial. And a big one that I think has helped me a lot is having been a trainer and a coach. I learned how to sell and how to speak with people. So I did initially struggle a lot more, especially when I was still a student. When I was on clinical rotations, I had some very rough challenges because when I first went into physical therapy school, I was of the perception that if I was going to become the best in the profession, I would need to have the best manual skills. I would need to know all of the fanciest modalities that existed. I'd need to know how to combine all these things into the most expertise ways. So I signed up for certain clinical rotations very early on and pushed for the best places for those things, which before I got to them, I started to change my perspective and was shifted away from that line of thinking, which made for an interesting few months and years while I was on and in these places where essentially I was involved in intraanal manual therapy techniques to help someone with an ACL injury, which was very confusing at the time. But exactly, the face that you're making is the face. Yeah. So I heavily struggled when I was in those settings, and still not as confident and able to be able to express my stance and be able to justify to the fullest degree. And it did come to a point where I had not only the person on the other end that was looking to have those things, because they came to the manual therapy specialists and they were expecting to have manual therapy for every single thing that they came in. And also I had clinical instructors who were heavily inundated in those belief systems and thought that that's what I needed to be a good clinician. So I definitely had a lot of deep conversations as I got further on into my time during those rotations, and had a little bit more wiggle room towards the end of that, the one I'm mostly focusing on. And then as I continued to win on more time, I got more confident in my abilities to express those things and speaking with other clinicians. Someone like Derek Miles, I don't know if you guys know who he is. He was a huge mentor of mine while I was still a student, and took a lot of time to speak to me, help me shift the way that I would be able to talk to other clinicians, help form the way that I could talk to my clinical instructors, and be able to have conversations about what was the best way that I wanted to learn, the best ways that I needed to have conversations about, and be able to start to push for myself to grow as a clinician, not just to be turned into a mini version of the clinical instructor. And that was a very good shift for me when I went into my third clinical rotation, or the last one in my profession. And during that time, I think it was like when I really started to catch way and was able to have these more deeper conversations. I worked at a high performance facility where we catered to professional football players, and they would come in, they had their strength and conditioning coaches who did the exercise. And then I was the guy that would give them a massage and Theragun them and needle them and whatever else. And so during that time, I was able to start having these conversations with the athletes about shifting, like what my role was and how I could really help them the best ways possible. And I still did offer a lot of those services, but it started to become less of, entirely that, and more about some of the key points that we discussed earlier of behavior management, because, a lot of professional athletes actually really struggle with many of those things. And starting to discuss, how can we change some of your exercise choices and selections, and how can I act as a more team role than just the person that rubs you for 15 minutes when your hamstrings are a little sore. So once I left that, then by the time I got to that point and I was starting to practice independently in a team setting, I was very confident and able to just really crush it. So from a standpoint of being able to express my stance and speak confidently on those things, by the time I was practicing completely independently, I felt comfortable having conversations with surgeons about changing protocols, being able to have a conversation about why we should look to do different things or focus on different points with physicians. And yeah, I was much more prepared, which I know is not the standard, but I think it's because I had some amazing mentors who really pushed me and guided me, and not only how on what I should do, but also how to also express that point and be able to justify it. Because as much as I've met a lot of students that are working towards having greater comprehension of some of the details that we've discussed, they may not feel like they're actually able to have that conversation with a patient or with another clinician or with another healthcare professional. And it can be a really hard thing to do. And you really, to do a best job, need to understand how to have conversations with people about difficult subjects, which is also not a thing that's commonly taught.
Do you see maybe a bit of a trend in, because you're talking a lot about the differences between high and low value care, lifestyle interventions? Maybe it's just because we've boxed ourselves into this echo chamber of good stuff, but it seems like there almost is like this slow push towards maybe calling out some of the BS on the internet and striving to educate patients better, break down some of the crummy narratives that can be associated with pain and other conditions. Yeah, I don't know. Like, I feel like there is a pretty good push there lately. Some good names. I mean, some are a little bit more opinionated than others. You got like the Adam Meekings, the Greg Leemans, you guys, like it's really good stuff.
Yeah, so I absolutely agree that I think that there is a current progressive push towards increasing the amount of high quality care and reducing low value care. And without a doubt, we are in our own echo chamber. But as someone who regularly pokes his head outside of the echo chamber on purpose and is trying to challenge my own bias, I do think that it is happening. You can even see in different journals where they are specifically focusing on points like that. It's really common to see in the Lancet them pushing out topics of how can we change low value care, what is low value care. And while that's not necessarily a journal that a lot of rehab clinicians are reading, the Lancet is one of the largest academic journals that exists, and it reaches a ton of healthcare professionals, and hopefully it helps to shift a more systemic level that would then elevate our professions respectively. Because, if you have more people outside of our little niche of rehab starting to question terminology such as like, what the fuck is a muscle trigger? Like if a physician starts to call out someone that uses that term, we are hitting gold. And at that point, then we know that we're good to go. So if we can continue to elevate the profession or across all of the professions, then we'll see better. And I think that's currently happening, especially given a conversation that we had earlier about like medical spending. So I think because a lot of the questionable interventions are low value care, they're going to get called out more and more as we continue on time. And we're seeing where a lot of that is happening driven by different things like insurance reimbursements and, a lot of professions struggling in different countries. Like in the US right now with the current COVID situation, we're seeing where a lot of outcomes aren't necessarily changing distinctly, even though they're being offered through telehealth, which is, you're not obviously dry needling someone through your webcam and you're somehow getting the same outcomes. So hopefully it's opening some people's eyes to different opportunities.
That just kind of leads to another point. I think you've done a really good job with some of your personal content in offering different exercises, because you usually see a lot of pages where it's just like, you have sciatica, so do these 3 exercises for that quick fix. And I think you show a lot of different progressions in exercises and kind of put this little caveat, like this isn't a fix all for everyone. Try it. This is something that you can do. And just another discussion that we have is there's a lot of barriers to getting people to move and do physical activities. We might see some institutions or universities talking about how shoes matter. But I think you do a really good job at kind of breaking down some of those barriers. Where do you think we can be better with that?
So when we're looking at how can we reduce the barriers to participation, I think that a big impact is changing the way that we're demonstrating and voicing things on movement. Like if we somehow put these prerequisites, yeah, sure, like the shoes thing, like if you say that you can't squat unless you have a heel elevated shoe, or you can't squat unless you have like a special X, Y, or Z, then that's going to start to reduce people. But then also like the requirements on these different movements, like, okay, so you can't squat unless your toes point forward. Okay, well, what happens if that hurts? Well, you can't squat then. Sorry, you got to just work on it. And you have to force yourself into this little square peg or square hole and jam yourself as a round peg. Like it's just not going to work for a lot of people, and it's inherently going to start to create barriers. And then as we start to layer on quote unquote bad movements, like, if you're someone that has only 5-pound dumbbells at home right now during COVID, and you're trying to figure out what exercises you can do, and you find that this upright row is an awesome exercise that challenges your shoulders, but then you're told that you shouldn't do that exercise because it's bad for you and it's going to jack your shoulders up, and now you choose to do less challenging movements because they're quote unquote safe. Or so it just starts to layer on these more challenging things. And as we give perspectives to people that X movement is dangerous, X way is the only way that you can perform a movement, it just puts more things in the position to stop a person from choosing to do movement, and starts to make more opportunities for them to say, I'm good, I'm just going to sit on the couch because I don't want to deal with it. And in contrast, if we choose to be more vocal and start to express that, you can squat any way that you want, if we can start to say, here are all these different ways you can squat, and you know what, you don't even have to squat, you can do whatever you want, but here are a ton of different ways that you can choose to be active. You like to walk, go for a walk. But we have to give people those options and also help them appreciate how important some of this stuff is, because a lot of people, I think that there's a stat out there about like the number of people that think that they need to be active. And if you look at the number, it is pretty high. I think it's like 60 or 70%. But the scary part of that number also is that there's 30 to 40% of people that don't think that they need to be active. Like that's kind of crazy if you think about it. And so if we're seeing like these really low numbers of percentage of people that know they need to be active but aren't, well, we do want to reach those people, of course, but we also need to try to reach these other people that don't think that they need to be active. They don't think that there's any value in that. And so trying to be able to reach all of these people is going to be really important. And us doing that as clinicians in the rehab setting is going to be valuable, having conversations about why they may benefit from changing their current lifestyle habits in regards to exercise and physical activity for their pain management and their also general health and quality of life. Then also having that done in other settings, because we have tons of people that don't see rehab professionals, or at least rarely see them, but are seeing people like physicians, registered dietitians, all these other healthcare professionals that could have that conversation. Like, I'm not going to start saying an optometrist should be telling people that they need to be physically active, though there is an argument to be made there. Nonetheless, if we can have at least other professions having that piece of conversation and also empowering them in solutions for it. Like if you just go to a physician because you are getting a regular checkup and they ask you how physically active you are, and you say, yeah, I walk 5 minutes a day, I do nothing. And they say, well, you should try to improve that. Like, it's not going to be that valuable. But if they can provide them with, here are some local resources on how you could change that. Here are some suggestions on some options to actually shift you to being more physically active. It would give the person way more likelihood of doing that. So I think it has to come from, again, like a systemic level of, social media, also like general evidence and being progressed down, but also from a grassroots level of each individual clinician across multidisciplinary healthcare professions.
Yeah, I think sometimes too, just the fact that people aren't getting this advice is because we're maybe not individuals, but as a whole, we're pretty bad at listening to patients and listening to what they think is on their mind, their points of view of why they might have pain or why they might have an issue or what's realistic for them, right? And it's always just like, okay, you have this, so do this or do this. And maybe those are the two options that they're just like, it doesn't make sense to them. So we had this conversation with like Oliver Thompson, and basically everybody who comes on, they talk about how it's important to listen. It's important to use the right words and stuff. Have you seen, I guess, your assessments or intakes with individuals? Has that changed quite a bit over the last couple of years in terms of you letting them tell their story?
Yeah, so I would say that it's shifted a lot. One of the big things that I've done now is, if possible, I have people actually fill out this intake form that I have before I meet them. And if this is online and I'm working with someone through telehealth or like distance rehab coaching, anything like that, it's obviously going to happen. But then even if I have someone who schedules and books with me and it's not like, I'm going to see them later today, if I have a day or two in advance, I send them this intake form, ask them to fill it out ahead of time. Most people will do it, and it's primarily focuses on questions like, what do you think is going on? What do you think needs to happen to see change? What do you think has led to this triggering or is impacting this from all these different options? And then I have things like, do you have any lifestyle issues that are going on that may be contributing? Do you have any sort of activity issues that might be contributing, et cetera? And that's something that I've introduced. I had initially started to do roughly like 2 to 3 years ago, but I've now started to push how much I focus on getting that out to people before I speak to them. And even when we're just having this initial conversation, something like this with the patient, I try to really focus on asking these open-ended conversation starters and seeing where it takes us across the next 15 to 20 minutes. Most of the time I have people for a 45-minute appointment to start off with, and usually the first half is just having this open-ended conversation and just seeing what the person thinks and trying to get as much of like their conceptual idea about not only what they think is going on, but what needs to happen to go forward and what they expect from me. Because I know what I want to do in most cases, and I know where I'm probably going to have the conversation go. And if the person is at a completely different point in time, like if they really confidently think that they have back pain and I need to pop their back to get it feeling better, and that is legitimately the only way that they think it's going to get better, we're going to have a much different next half of that appointment than if it was someone that was like, yeah, I don't know. I just have never had back pain before in my life and I don't know what to do. Okay, well, this is a different conversation. And so I think when we start to look at the literature that's available on expectations of people, when we start to see when they compare interventions that are provided and how that matches up with the person's expectation and the results that we see from it, we see more and more times than not that if someone has more of an expectation of an intervention, like a stronger expectation that they will get a good result, we see a stronger result. And so then if I can appropriately shift that person's expectations to be in line, or have a conversation even about that piece. When I have people come in that are very much, manual therapy or modality based in their mindset, I have a conversation about expectations and beliefs. And, I don't like sit down and give them a statistic and just like randomly read them research, but we have a bit of a conversation about it and see where we can meet a common point to start to move forward with. And that's only done because I make sure to figure out what they think, and at least to some degree. And a big part of that is like motivational interviewing and trying to find out as much as possible from their standpoint.
There's like this great Scott Haldeman quote from like a 2012 commentary, and I'm not sure if Scott Haldeman is big in the PT world, but he's considered like the chiropractic god because he went and did an MD PhD afterwards. So he's been involved in spinal pain. But like the great quote from 2012, and I'm paraphrasing, is along the lines of like patient expectations and patient preference matters when the outcomes are the same of the two intervention options. That's when patient preference really matters. But when a patient comes in and they want something, and you look at the objective results that we've seen in research that it's probably not a good treatment, like that's when, like you just said, that has to be a conversation about mindset shift, why they feel so associated with that, because otherwise we're spinning our tires in mud a little bit. And I've been wanting to ask this question for a little while, but I think it's just maybe important that we ask it, is like, how do we define low value versus high value care? I think this might be the last one, so I don't keep you all day. But because consistently low value care is defined as like spinal fusion. That's probably a low value care long term, but surgery is not the only low value care we can provide to people, right? So can you just talk about like your perception and kind of how we see on that?
So just to like clarify, because you said this off the cuff and you probably didn't exactly mean it, but like surgery is not always low value care.
Yes, correct.
Like for instance, yeah, exactly. So I don't
good,
want people
good correction. Yeah, no, surgery is very, very much warranted sometimes. So let's put that out there. Yes.
And the whole distinction of low value and high value care is, I would say, currently not very clear. And that we do have some general definitions that are out there. Like recently, again, in the Lancet, they've been discussing it. So I think that they have a definition, but I don't have that off the top of my head. But I can give my current best definition, which would be treatment that has a benefit that is definitively superior to sham or placebo and has a longer lasting impact on the desired outcome. So kind of a vague term, but essentially, if we're comparing this intervention with a pretend version of it, does it provide better outcomes? And does it have an effect on the outcome that we're looking at? So if that is pain, it doesn't have to be pain though. Does it have that benefit over a longer term period of time? A lot of times we really focus on pain, but there are tons of different outcomes that can be really important, particularly from a value standpoint, like the quality of life, different outcome measures that we could use that measure aspects of quality of life. Something, like the WOMAC, which is an option to measure different aspects of function. We could be looking at it from an ACLR rehab outcome measure, or tons of options. And it's just about like, do we see that distinctly change in a way that has a better outcome for the person, particularly in the long term, than if we just did a pretend treatment? Like the example of dry needling, is the outcome that we're expecting to see better for that patient from dry needling versus poking them with toothpicks? If the answer is yes, then it is at least an argument for more of a high value care. I think that a lot of times when we're looking at the low versus high value care, there's the distinction that I just made, but then also a conversation about effect size. And the challenge with the effect size is that a lot of what we do in our professions doesn't necessarily have a lot of large effect sizes. So it gets a little bit trickier to put a strong distinction on effect size there. But yes, that would be my operational definition. What's your guys's?
No, I mean, I think so. Again, you pretty much summed up how I feel about it too. I like looking at, again, effect sizes is something that I don't think a lot of people fully understand what that means, right? Because again, I think we even struggle with statistically versus clinically significant. I don't think people have an understanding of what like a PASS versus an MCID is. Like there's lots of things that we're still developing for our outcome measures and research that I don't think we have a full understanding of. But for me, one of the big ones that I've found myself looking at a lot when we're comparing these interventions is the number needed to treat, because that's, I think low value care starts mattering a lot when we look at the financial burden. And like, again, like before, is in the US, surgery is really expensive. So that's a large financial burden. In Canada, surgery is covered. So that becomes a slightly different conversation sometimes. But what I mean with number needed to treat is if we have an intervention study that shows that the number needed to treat is 7 people to create a result, and that protocol is 16 treatment sessions, you're looking at what, like 112 sessions to create one positive result compared to the other control. And I think that's how we start defining low value care. If we put $50 on each one of those treatments, it just took $5,500 to help someone, and we haven't even discussed the effect size of that help yet. Like that's the conversation that I want to start having. And I think that's the conversation that you're pushing as well with people, right? Like what is the absolute timeline that we're providing to people, and what is the cost associated with that to create a positive result? So that's me. I don't know what you guys got anything else. That's my long-winded one.
Another way that I look at it, I mean, the big way that I look at it is basically what Sam said, where it's, is it better than something that is been faked or placeboed? Like the placebo mechanism is incredibly powerful and it does have an effect, but placebo exists in literally everything that can be done. But we look at secondary outcomes. So the more secondary effects that something has, generally the higher value it is. So looking at something like a manual therapy, like you're talking about with the mobilization of the hip with osteoarthritis we were talking about earlier, it provides a short-term primary effect of a short-term pain reduction. That's all it does. For a few hours, maybe it makes them feel a little bit better. Meanwhile, if you had them, instead of doing that, you had the patient performing some strengthening exercises and some aerobic exercises for managing their osteoarthritis. From there, you get the same reduction in pain because the placebo mechanism for pain is still present, but then you also see an increase in cardiac output, muscle strength, hypertrophy, self-efficacy, so the belief that you can manage things on your own, positivity, all of the other great things with that come with exercise as well. So if we can have the same effect, like the placebo effect exists with exercise plus all those great things, and the placebo effect exists with this manual therapy, and that's it. Well, let's go with the thing that does a whole bunch of great things instead of just the one single outcome, which is minimal.
People are going to get mad at you about that one. They're going to get mad. People hate that argument.
My phone number is 555-1234. Text me and get at me.
I think you guys have basically said everything. I can't really add a whole lot more on, but Sam, you made a point earlier in regards to, your price range for the services that you offer is X. And sometimes I think money plays a big factor in it, especially with new clinicians. They just want all the money that they can get. So someone comes in with a couple of different issues that maybe someone else would be better for them, and they're like, well, I can try to fix that. Like I can still try to bring your pain down, when realistically, send them to the strength and conditioning coach that does a pretty good job with that stuff, and they'll get far more benefit out of that. So I think sometimes we need to maybe stop being selfish and thinking that we can fix everything and take everything into our own hands. And, although it doesn't bring the same kind of money in, I think patients are pretty damn thankful when you're like, I think you'd probably do better with this. So I think that's great that you're doing it.
Thank you. And I just want to touch on that point, actually, because when I discuss that, a lot of times people bring up the argument of like, how do I even survive if I'm just sending away all my patients? And, because I don't actually treat from a standpoint of like multiple treatments. I don't treat a lot of people. Most of what I do is evaluation and then referral to an appropriate person after that. And for me, that's I have a large network of different healthcare professionals, a large network of personal trainers in my local area. And then I also offer services to people from a training standpoint, in addition to like my rehab professional standpoint. And that's at a lower rate and different options for that. So that's one of the things that I do. But additionally, because I've actually worked with all these different people in my local area of finding ways to refer them appropriately and doing what is probably the best value for the patient from my standpoint, they are very soon to refer me. And also my patients are very soon to refer me. So like my schedule is fully booked all the time. I don't treat a ton of people, but nonetheless, like if I opened up my schedule to a higher degree, I would probably fill it up soon enough. So it was initially less volume for me and less money in my bank, but over time, as I built up a reputation in my local area for offering a high value and giving people a service that they found really beneficial, then it started to just send me lots of opportunity for work.
Yeah, that's
So
awesome.
you're seeing more people less frequently rather than seeing less people more frequently. So the numbers in your schedule end up being pretty well the same.
So
yeah,
let's put this on the record then, because we've been told one of the quotes was, "Good luck making money off of education and reassurance." So on the record, you can make an ethical living by keeping volume low and stuff, depending on what the patient needs. So that's great to hear, Sam.
On the record, I don't make $1 million a year.
Yeah,
but I am making a living that is enough to support my family. I am purchasing my home. I have a mortgage, but I pay my monthly bills. I pay my rent on my clinic. I pay all of my bills, and I'm paying off my student loans at a reasonable rate, and I will eventually be able to retire.
Can we put on the record that you're paying a mortgage in BC too? So let's not
Man,
downplay that. Congratulations.
I wish. No, I would still live here because I love the place that I live, but I did not know all of the taxes associated with living in this province.
Congratulations. You
Who
played
would have
yourself.
who would have known that a 1-bedroom storage unit could possibly go so high, right?
Well, if you live in Vancouver, that's the conversation. Once you move out of Vancouver, it gets more reasonable from that standpoint. But the taxes associated with purchasing a home are very high. The taxes associated with working are very high. Yeah.
But the healthcare is free.
I was in
Well,
Swamp.
actually, it's not. So everyone thinks healthcare is free in Canada,
No.
which I know that it's an off the cuff joke, but it's so funny because we pay taxes at a higher rate to reduce our healthcare costs, but then also, I don't know if it's like this in Ontario. I know in Alberta and BC, we have to pay like a yearly fee as well for healthcare. Do you guys have that?
No, we just
BC, in BC, it used to be monthly. So
we pay. I mean, we still pay things like
extended healthcare benefits and stuff like that.
Yeah, like optometry, dental, all that stuff's not healthcare, right? Like that's hilarious.
No.
That like your teeth, that's not healthcare.
Yeah.
So
Your eyes, they're not important.
no.
No.
I had one, and it's kind of like a 90-degree turn here. We put out a little piece in terms of posture and how maybe people are giving it more credit than it's due in terms of how it's related to pain and other issues. We got some flack from some colleagues on that, basically saying we were saying it wasn't important. And then I saw a really good like carousel post that you did, and it put everything into from a really good perspective. So if you have 3 minutes or so, your crash course thoughts on what is the role of posture when it comes to musculoskeletal pain.
Yeah, exactly. I think it's one that I've taken a lot of heat on myself for, and I've tried to progressively work on how well I communicate my stance on it because of the amount of heat I've taken. So I think that a big detail that often gets challenging with it is the concept of correlation and causation. And, first thing is that, number one, posture does not cause pain. It may be correlated with pain depending upon a lot of factors, but nonetheless, most things in life have a correlation. So I would never say that there's no correlation. As we start to get into the weeds of how important that correlation is and how we should choose to focus on it or not is more of the details that get into the nuance of it. So in my stance, I think that, posture is something that we can adjust within reason. It can, your resting posture doesn't necessarily change drastically, but we can easily move positions. If you cue someone to do so, we can create lots of reminders where necessary. But the value that we get from changing or focusing on posture is maybe not that strong. When we start to look at the literature that's present on if someone has X posture, does it mean that they will have pain? It's not really supported. But if someone has pain with, they have cervical pain while they have a forward head posture, am I going to tell that person, never change your head position? Like, no, I'm not going to say that. Like, if moving your head feels better, move your head. That's fantastic. Let's do it. And we can work on other things at the same time. I'm just not going to tell that person the reason they have pain is because their head was forward. It's like you are currently sensitized to that position. It's maybe something that you need to spend a little time away from. We need to work on some other factors. But my goal is to be able to allow you to rework your way there over time and have no concern, no hesitation, and no symptoms or as minimal symptoms as possible. And that way you can feel confident and robust in every position that you desire to be in. The key centerpiece of that is the education aspect of that. None of these positions are causing your pain. You're just, currently sensitive to it, and none of them are inherently bad. You can sit in a highly flexed posture and you're going to stress certain tissues. You can sit in an upright posture and you're going to stress certain tissues. You can sit in an extended posture, stress certain tissues. And these tissues are going to be different. They have a different amount of load capacity, but nonetheless, you're challenging them. And sometimes people just can't tolerate the amount of load that we're putting on those ones for a certain reason. And that just means that specific one is not maybe the right posture at that current time. And we just need to find one that you're comfortable with hanging out in, and then work our way to being able to tolerate it over time. That might be a thing where we have to do graded activity exposure, or it might be a thing where you just need a little time away and then it's just good to go. It's hard to say. So I don't know if that covers the exact carousel that you said, because I've got a bunch of them, but
that's a pretty good one, and you put it really well there. Like, it's maybe just not the right thing for this time, because I think sometimes people start getting some fear avoidance behaviors because it was explained that that's why they're in pain with that head forward, right? Which can sometimes lead to more co-contraction of them always trying to be a little bit more upright, and then cause the snowball effect, right? So again, words are pretty important, but that's a great way to put it. And I think maybe we shouldn't be using some of those low value modalities that do the short-term pain effects for, claiming that they might do long-term, and I say this in quotations, postural fixes, but yeah, really nicely put there.
Yeah, exactly. And I think like we have, as you said, the words matter, but then also everything that we do with the patient can provide a subtle cueing system that may tell them, or at least give them the perspective that certain things matter to a higher degree, or certain things, have different value in it. When I go and I meet with a patient, I'm often varying my posture depending upon the conversation that we're going through. If I have someone who sits up really upright, sometimes I purposely slouch while I'm talking to them and just like give the respective feedback that like, I'm not hyper focused on it myself, making sure to sit upright and have my chin retracted back. And because if I'm saying that these things don't matter, but I'm personally maybe not showing that, or throughout the whole session, I'm telling them that they can slouch, but at no point I slouch. Like, how much do I necessarily have confidence in that statement too?
That's a great end.
I think that's a great way to end it. Yeah.
Yeah. I guess the last thing is this is your time to shine, and let people know what projects you're kind of working on, where they can find some more of your great content. Let the world know a little bit more about Sam Spinelli.
You can find most of my content on Instagram, either on my personal page, dr.samspinelli, and then you can find Citizen Athletics 1 for fitness-related content, E3 Rehab for more rehab-based content. We have YouTube channels. We have Facebook. We got a podcast for E3 Rehab, trying to do everything we can to shift some narratives. So you can follow any of them. We just keep sharing all our stuff. So.
Honestly, Sam, thank you so much. It was great to hear some of your perspectives on, a variety of topics. So thanks again.
And thanks for all you do, because it's nice to see. It is a rare glimpse of sunshine to see good content being sent out to people with a pretty substantive following, because there's a few million plus accounts that are not necessarily always doing that. So thank you.